Welcome to our Clinician's Atlas. In this explainer, we're going to master the techniques for 4 really essential nerve blocks. The goal here is to sharpen your skills and really lock in that anatomical knowledge.
Every single successful block starts right here, with a really clear map of what I like to call the neural landscape. We're going to be focusing on the 2 main pathways for all dental sensation. That's the maxillary, or V2, and the mandibular, V3 divisions of the trigeminal nerve. Seriously, mastering their anatomy, it's the foundation for everything else we're about to do.
All right, so here's our roadmap for today. We'll start with that foundational anatomy, then dive deep into mastering 4 key blocks: the INB, the PSA, the ASA, and the GP. And then we'll wrap it all up with a handy field guide to make sure these techniques stay sharp.
Okay, so let's start with that foundation. A deep, practical understanding of these V2 and V3 pathways. It's not just some academic exercise. It is the key to procedural success, and maybe most importantly, to your patient's comfort. All right, first up, the true workhorse of pretty much all mandibular procedures, the inferior alveolar nerve block, or the INB. If you're working on the lower arch, you know this one. This is your go-to day in and day out.
So what's the whole point of the INAB? What's its mission? Well, it's designed to get an entire mandibular quadrant numb, all the way from the molars right up to the midline. This makes it perfect for when you're working on multiple teeth or when you need both the cheek side and tongue side tissues numb.
Okay, with this one, precision is everything. Just look at this diagram. Your key landmarks are going to be the coronoid notch, that deep curve on the anterior part of the ramus, and the pterygomandibular raphe. You're going to align your syringe barrel with the occlusal plane, and you're aiming for that spot just above the mandibular foramen. And for this, a 25-gauge long needle is usually what you want, just to make sure you have the read.
Let's walk through this step by step. So, your patient is supine, mouth open nice and wide. You're going to use those landmarks we just talked about to find your injection plane. Then you bring the syringe in from the opposite corner of the mouth. Now, advance it smoothly until you feel that gentle contact with bone. That's your backstop, right? Then you just withdraw ever so slightly, aspirate to make sure you're not in a blood vessel, and then slowly, very slowly, deposit that anesthetic.
Okay, this is so important. We have to talk about a really critical distinction here. When your patient says their lip is tingling, that's a subjective sign. It's a good start for sure, but it is never a guarantee of pulpal anesthesia. The only way you can know for certain is with an objective sign, like getting no response from a pulp tester or a freezing spray. That's when you can proceed with real confidence.
All right, let's head on up to the maxilla. Now we're going to look at the high approach for those posterior teeth, the posterior superior alveolar block, or PSA for short. The PSA is really our go-to when you're treating 2 or more maxillary molars. And its big advantage? It's got a super high success rate, and when you do it right, it's actually very comfortable for the patient. And that's because you're depositing into a large, soft tissue area, without having to aggressively contact bone.
But, and this is a big but, here is a critical clinical pearl you have got to remember. In about 28% of patients, that's more than 1 in 4, the mesiobuccal root of the first molar is not anesthetized by the PSA. This is such a common reason for incomplete anesthesia. It just means you might need a second, little supplemental injection to get that specific spot totally numb.
Now, even with that little exception for the first molar, don't forget this number. The overall success rate for the PSA block is over 95%. That is an incredibly reliable technique. It's one that should give you a ton of confidence every single time you do it.
The technique for this one is pretty unique. It's a real 3-dimensional movement, and this diagram shows it perfectly. It's all one smooth motion. You're going to advance the needle upward at about a 45-degree angle to the occlusal plane, then inward toward the midline at another 45 degrees, and finally backward along the long axis of that second molar. I like to think of it as you're gently hugging the maxillary tuberosity as you advance.
Okay, let's lock in a few key pearls for the PSA. A 27-gauge short needle, that's perfect for this. Always keep the bevel of the needle oriented toward the bone. That'll help minimize any discomfort if you do happen to make contact. Now, if you hit bone too early, that's a sign your inward angle is just a little too sharp. And remember, the biggest risk with this block is a hematoma, which is exactly why a precise, gentle technique is just so critical.
All right, let's move forward in the mouth now and tackle the anterior arch. We're going to do that with the ASA, or the anterior superior alveolar block. This one is a wonderfully simple and safe technique that covers a really broad area.
The ASA block is just fantastic for when you're working on more than a couple of maxillary anterior teeth. It reliably gets everything from the central incisor all the way back to the canine. And get this, in about 72% of patients, it'll also numb up the premolars and even that tricky mesiobuccal root of the first molar. That's a whole lot of coverage from just one single injection.
The absolute key to this block is all about your sense of touch. It's tactile. So before you do anything else, you have got to find that infraorbital foramen. Feel for the infraorbital notch, and then just slide your finger down until you feel that little depression. Now keep your finger right there. That's your landmark. Retract the lip and advance your needle right from the mucobuccal fold straight to your target. Okay, for our final technique, we're heading to the roof of the mouth. We're talking about the greater palatine, or GP block. This one is absolutely essential for getting those really hard-to-numb posterior palatal tissues.
So yeah, the GP block is a must-know for any kind of restorative or surgical work on the posterior palate. Now, let's be honest, this one can be pretty uncomfortable for the patient, but a really precise technique, which we're about to cover, can make a huge difference in their experience. And here is that technique. The whole trick is something called pressure anesthesia. First, you're going to take a cotton swab and find the foramen. It usually feels like a little depression just distal to the second molar. Now, apply firm pressure with that swab for a good 30 to 60 seconds. You'll actually see the tissue blanch. That's numbing the surface nerve endings. Then, while you're still holding that pressure, you bring the needle in right beside the swab and slowly deposit the anesthetic. I'm telling you, this minimizes the discomfort in a huge way.
Whew. Okay, so we've just covered 4 major blocks in a lot of detail. Now let's pull it all together. Let's synthesize everything into a single, high-yield reference guide that you can really take with you.
And this table just lays it all out so clearly. It really highlights the key differences. So for the INNB, what's the big pearl? You got to confirm with objective signs. For the PSA, remember that 28% rule for first molars, they might need a second injection? The ASA, it's all about palpating to find your target. And finally, the GP, the key is that pressure anesthesia technique. Seeing it all laid out like this is just a fantastic way to reinforce your technique.
You know, when you boil it all down, it really comes to this. That deep anatomical knowledge, that's your foundation. Your careful, precise technique, that's the execution. And when you combine those two things, the result is the goal that every single one of us shares, providing confident, effective, and truly atraumatic care for our patients.
So I'll leave you with this final thought to kind of chew on. As you keep refining your own skills, think about this. What's the one clinical pearl, that one tiny adjustment that has made the biggest difference in your anesthetic technique? Really thinking about that. Well, that's the key to always getting better. Thanks for joining me.